Hello, hello, can you hear me? Can you hear me? Can I have some help, please? Code blue in the training room.
When you arrive on scene, the first thing that you need to do is check for dangers, you check for a response from the casualty, and you check the airway. Quick look at the airway, and then move swiftly on to check see if the casualty is breathing. First circle is the 999 and call for help. Once you've got the code blue initiated, there'll be a response.
9, 6, 7, 8, 9,
Hi.
10.
Okay. Yeah, 55-year-old cardiac arrest. Can you go get an ambulance, Michaela, please?
The second ring in the chain of survival is early CPR, cardiopulmonary resuscitation. The quicker you go onto the chest, uninterrupted CPR, the better the outcome.
2 vents. Okay.
3, 4, 5, 6.
And the third circle is early defibrillation.
Okay, everybody standing clear.
The defib is going to do an analysis if there's any cardiac output.
Analyzing rhythm. It is now safe to touch the
Okay,
patient.
no shock advised. Do you want me to take
Start
over?
CPR.
Amanda, can you coordinate the response and get the ambulance for me,
Will do.
please? Thank you.
3, 4, 5.
You need a team leader to coordinate the response and also to give a confident handover to the emergency services when they arrive. And it can be any suitable person that wants to take on that role.
1, 2, 3, 4.
Inevitably, ribs will break during CPR. Please don't be fazed by that, because it's better to have cracked ribs. They can be repaired later than to have somebody that is deceased.
29, 30.
2 breaths. The AED, which is the automatic external defibrillator, has got a built-in metronome. Sometimes this can be confusing because your timing may be out of synchronization with the machine. Don't worry about that. Count out loud and continue. For the purposes of this scenario, the mannequin that we've got that we continue to do the resuscitation and the defibrillation on is not fit for purpose for doing airway management. We've now moved on to a different mannequin which we can demonstrate the different adjuncts and methods of managing an airway. So I'm ventilating the patient using the bag valve and mask, and I've got the head tilted so that the tongue is away from the trachea. But I now need to secure with better adjuncts of airways. So I've got 3 options that are available to me. The nasopharyngeal, the oropharyngeal airway, and the I-gel. Okay, the first one I'm going to insert is the oropharyngeal or the Goodell airway. Okay, after ventilating the patient, we're now going to insert the oropharyngeal or the Goodell airway. To do this, we go in with the end, the lumen, facing the upper palate. So we enter in and then twist and rotate nicely into position there. So what we're now going to do is insert the nasopharyngeal airway. Okay, we put this into the right nasal nair. The reason we choose that nair is because it's the largest of the 2. If you enter into the right nair and you meet an obstruction, a nasal polyp or something like that, then don't force it, take it out and use the left nair. We lubricate and apply it with a little gentle scissor action as it goes into the nasal pharynx. And that secures the airway from 2 perspectives. Now I've got both airways secured, I can now ventilate the patient. After ventilating the patient, what I'm now going to do is introduce the I-gel, which is the gold standard, the best method of securing the airway. But you as the ventilator or the person in charge of the airway has full control over the patient. So under no circumstances must you leave the patient once that's inserted. Really straightforward manoeuvre, but I need to remove the oropharyngeal airway first. To do that, I bring it out following the normal line continuity of the mouth and jaw. To introduce the I-gel, it's a fairly straightforward manoeuvre. You may have to lubricate it, but it's important to only lubricate the back of the I-gel and not around the seal. There's a little hole in there, so if the patient does aspirate or vomit, then it can be sucked out from the top bit. Place the index finger down the tube just under the lip. Then apply to the patient's mouth, pressing as far down as you possibly can see in situation, like that, and then push it and it goes into the right position. The next thing we're going to do is ventilate, because the patient has had no oxygen. Take the mask off. This is the catheter mount, and we apply that to the bag valve and mask, like so, pushes on. And then we push this end of the catheter mount onto the eye gel, supporting the eye gel as you place it. And then you're now in full control of the patient's airway. One hand on the eye gel and one hand on the bag of mask. And then we'll listen for bilateral air entry to make sure that your eye gel is in the correct position. And once we've done that, then you can secure it using the ligature to keep it in place. Continue ventilating the patient, and CPR is continuous throughout, using the defibrillator and following the normal resuscitation process. When the ambulance come and you fulfill the final ring of the chain of survival, which is handing over to definitive care, and the paramedic will then take over with the drug therapy and introduce the cardiac arrest drugs. You may still have to maintain the airway. Ensure that the team leader is readily available to give a handover to the paramedic or to the ambulance crew, and they know exactly where you are in the resuscitation process. The media often identifies that you see people in a cardiac arrest situation doing a lot of extra things than what they've been taught. It's so important that you keep within the parameters of your training and what you've been taught to carry out. It's important to remember that things often go wrong in a cardiac arrest scenario because there's lots of things going on, which is the importance of having a team effort and nominating a team leader who can coordinate the whole response. That way, things aren't missed. You're not alone, you're part of a team.
I hope you enjoyed the video. It was designed to be educational, but I hope it was interesting as well. We certainly don't see it as a replacement for any of the first aid training you get or your Code Blue practices. It's certainly something that will enhance your learning and your learning opportunities.